Good morning, students.
Got it, sir.
The topic of today's lecture is basics of anesthesiological pharmacology. Local anesthetics. These drugs act by blocking the conduction of nerve impulse along the axis. Small diameter and myelinated fibers are blocked first, whereas unmyelinated and thick fibers are blocked at last. Thus, the order of blockade of fibers is B, C, A, and then A, B, and gamma autonomic fibers are blocked first. Then sensory cold temperature sensation is lost first, followed by lost pain and proprioception. And finally, motor are blocked at last. Order of recovery is on the reverse order. Local anesthetics can be classified into amide and ester types. Amides are usually long-acting and chances of allergic reactions are less, whereas esters are short-acting due to metabolism by esterases present in the plasma. Ester alase can cause allergic reactions and also antagonize the action of sulfanilamines due degradation of PADA. There are amide class, lidocaine, prilocaine, bupilocaine, dibucaine, mepilocaine, atidocaine, ropilocaine, and also ester class, cocaine, procaine, chlorprocaine, piperocaine, benzocaine. Mechanism of action. All LAs are weak bases. These drugs act by penetrating the axonal membrane in unionized form and blocking the voltage-gated sodium channels from within in ionized form. Sodium bicarbonate speeds the onset of action of LAs by increasing the unionized form. Weak bases are unionized in the alkaline medium that can penetrate the axonal membrane. Vasoconstrictors like adrenaline, epinephrine can prolong the duration of action and decrease the systemic toxicity. Alternative vasoconstrictor, phenylprecin, synthetic vasopressin, can also be used with LAs in order to avoid cardiovascular complications due to adrenaline. Lidocaine with adrenaline should not be used for areas with and arterials for ring block of fingers, toes, penis, pinna, absolute contradiction. When an inhalational agent, especially halotane, which sensitizes myocardium to adrenaline, is used, myocardial ischemic patients, hyperthyroid patients, severe hypertensives, intravenous regional anesthesia, Beer's block. Small diameter axons are more susceptible to block than large diameter fibers. Myelinated fibers are more sensitive than non-myelinated. Sequence of block is type B more than type C and more than type A. In functional terms, autonomic, then sensory, then motor. Among sensory fibers, sequence of block is pain, then temperature, cold before heat, then touch, deep pressure, proprioception. All LAs are vasodilators except cocaine, act as sympathetic mimetic due to inhibition of noradrenaline reuptake. which is vasoconstrictor. Therefore, all LAs decrease BP except cocaine increases. Cocaine should never be given by intravenous route or with adrenaline. Cocaine is the only ester which is not metabolized by pseudocholinesterase. It is metabolized in the liver. Procaine is the local anesthetic of choice in malignant hyperthermia. Chlorprocaine is the shortest acting local anesthetic and is contradicted in spinal anesthesia. It may cause paraplegia due to the presence of sodium metabolism feed as preservative, which is neurotoxic. All LAs of absorbed in systemic circulation can cause CNS toxicity that manifests as excitation followed by depression. Initial excitation is due to inhibition of inhibitory neurons. These LAs may lead to seizures followed by coma at high doses. Ibuprofen is the most potent, longest acting, and most toxic LA, whereas chlorprocaine is the shortest acting LA. Lidocaine is the most commonly used LA and is the drug of choice for ventricular tachycardia. It can precipitate malignant hyperthermia due to release of calcium. Dose is limited to 7 milligrams per kilogram with adrenaline or 4 milligrams per kilogram without adrenaline. Bupivacaine is the best drug for regional blood, but it is also the most cardiotoxic LA. Due to cardiotoxic effect, it should not be used for beer block. It is the most potent and longer acting lidocaine. Addition of adrenaline does not significantly increase the duration of action of this drug. For spinal anesthesia, 0.5% solution is made hyperbaric with 8.25% dextrose in water. Its maximum dose is 2 milligrams per kilogram. Most common ECG changes in bupivacaine toxicity are idioventricular rhythm with broad QRS complex. Beryllium is the drug of choice for bupivacaine induces ventricular tachycardia. Propiocaine is less cardiotoxic congenere of bupivacaine. Prilocaine produces a metabolite or toluidine, which is an oxidizing agent. Later can oxidize hemoglobin to hemoglobin that can cause methemoglobinemia. It is the most suitable LA for Beer's block. Benzocaine and lidocaine also can cause methemoglobinemia, but less than prilocaine. Oxytocin, mucaine, can be used to provide symptomatic relief in gastritis. It remains unionized in the acidic pH of stomach. Uses of local anesthetics. Surface anesthesia. It is a topical application of LAs to mucous membranes and inbreeded skin. Only superficial area in anesthesiates. Lidocaine is a commonly used agent for topical anesthesia of mucous membranes of nose, ear, eye, mouth, and pharynx. It is also used during proctoscope catheterization and rectal examination. Lidocaine is ineffective in intact skin. However, in mixture of 2.5% lidocaine and 2.5% lidocaine in 1-to-1 ratio can anesthetize even unbroken skin. Combination of these two agents lowers the melting point in individual drugs and helps to form a semi-solid ointment. The mixture is known as eutectic mixture. Oxytocin mucaine can be used to provide symptomatic relief in gastritis. It remains unionized in the acidic pH of stomach. Infiltration anesthesia. LA is infiltrated subcutaneously in the area of operation site for blocking the sensory nerve endings. It is used in minor surgeries like incisions, excisions, suturing, hydrocele, etc. Adrenaline can be added to the LA to prolong its duration of action and to prevent systemic side effects. Nerve block. LA is injected around the nerve trunks supplying a particular area to anesthetize all the nerves coming to or leaving that area. It includes block of head and neck, stellate ganglion, trigeminal nerve, cervical plexus, and phrenic nerve block, upper limbs, brachial plexus, and wrist block, thorax and abdomen, intercostal nerve, celiac plexus, lumbar-sympathetic chain, inguinal nerve, iliohypogastric nerve, pineal and paravertebral block, and lower limbs, psoas compartment and perivascular block. Pneumothorax is the most common complication of brachial plexus block. Intravenous regional block, Pierce block. Intravenous regional anesthesia, IVRA, is indicated for any procedure on the arm below the elbow or leg below the knee that will be completed within 46 minutes. An intravenous cannula is inserted in a distal vein in the limb scheduled for surgery. The tourniquet is then applied to the upper arm or thigh. The local anesthetic solution is then slowly injected into the cannula. Analgesia will occur within 3-4 minutes and surgery can then commence. The pressure in the tourniquet must be maintained at least 50 mm Bg above the patient's systolic blood pressure. The drug of choice for IVRA is prilocaine, as it is the least toxic local anesthetic and has the largest therapeutic index, but it is contraindicated in people with sickle cell disease because of metahemoglobin formation. If prilocaine is not available, lidocaine is an acceptable alternative, maximum dose 4 milligrams per kilogram. It is essential that plain and not adrenaline-containing solution are used. Bupivacaine should never be employed as it is too toxic, particularly to the myocardium. Spinal anesthesia. It is injection of LA in the subarachnoid space between ear and arachnoid, also known as interthecal space in lumbar spinal cord. Spinal cord ends at lower border of L1 vertebra in adults. Thus, spinal anesthesia can be performed safely in L2, 3 intervertebral space in adults and L4, 5 space in children. Spinal anesthesia leads to creation of a zone of differential blockade in which autonomic fibers are blocked at 2 segments higher and motor fibers are blocked at 2 lower in sensory blockade. Different sensitivity of various types of nerve structures encountered during lumbar function in subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, and arachnoid matter. Drugs used for spinal anesthesia. Lidocaine, 5% in 7.5% dextrose, heavy or hyperbaric. Bupivacaine, 0.5% in 8% dextrose. Orthopedic surgery of lower limbs and pelvis. Surgery of abdomen all pelvic and perineal surgeries, hernia, hydrocele, testicular surgeries, gynecological and obstetric surgeries, hysterectomy, myomectomy, cervical surgeries, tubectomy, tuboplasty. Complications. Hypotension is the most common intraoperative complication. It can be prevented by preloading with alkaloids treated by head low position, Trendelenburg position, fluids, vasopressors, and inotropic agent. Other complications include bradycardia, respiratory depression, and cardiac arrest. Most common operative complication is headache, known as post-dural puncture headache. It is mainly occipital headache that occurs after 24 hours from any headache previously experienced by the patient and is imitated or made worse by the adoption of sitting or erect posture. It is relieved by abdominal compression, with which raised the venous pressure. Most common cause of PDPH is leakage of CSF through the hole in the dura mater. It can be prevented by using small bore needle. Treatment consists of lying down for 24 hours, plenty of fluids, abdominal compression, and sealing the hole by epidural blood patch. Other postoperative complications include urinary retention, paralysis of cranial nerves. Most commonly involved nerve is abducens 6 cranial nerve, meningitis, arachnoiditis, paraplegia, and cauda-equina syndrome. Contraindication. There are absolute based in cranial tension, uncooperative patient, shock, bleeding disorders, coagulopathy, patients on anticoagulants, thrombolytics therapy, infection at local site, septicemia. Relative, aortic stenosis, mitral stenosis, recent MI, block, spinal deformity, psychiatric disorders, CNS disorders. Epidural anesthesia. Epidural anesthesia is given in epidural space between dura mater and bone using Warhis needle. Epidural space from foramen to sacral hiatus, triangular in shape, and contains anterior and posterior nerve roots. Epidural with spinal nerves. Indications mainly used for controlling postoperative pain by continuous epidural through the catheter. All surgeries which can be performed under spinal anesthesia, upper abdominal surgeries, thoracic surgeries, and even neck surgeries. Painless labor, chronic pain due to cancer and other conditions. Spinal versus epidural anesthesia. Spinal anesthesia is highly reliable, easy to place, because it can be confirmed by the presence of CSF in the needle and loss of resistance, and has very quick onset. However, it can be performed only for surgeries of limited duration. Redosing cannot be done if the procedure takes longer time than expected. PDPH is a very common problem. Epidural anesthesia is difficult to perform, requires expert persons, and therefore is less reliable. Further onset of anesthesia is like surgeries of Chances of PDPH is very low because it is quite superficial procedure. With emergency treatment. If a ray is inadvertently injected in the bloodstream, severe toxicity appears. It manifests as neurotoxicity and in high doses, cardiac toxicity, management of LA toxicity. First, 20% interleukin IV at first sign of toxicity. Second, benzodiazepines are drugs of choice for seizures. If not able to control, give succinylcholine. If not available, use propofol. Third, lidocaine and other class IV drugs avoid of arrhythmias. Natrium bicarbonate for severe acidosis. Thank you.
Thank you, sir.